Okay, so, sorry. One of the classical and major problem is to try to dissect which are the mechanisms that are operating in the different phases of the disease. This very famous slide suggests that we have two major phases in the disease, the progressive phase of the disease and the relapsing phase of the disease. So the relapsing phase of the disease in red is driven by dysfunction at the periphery of the immune system. Vice versa, the central, the chronic phase of the disease is driven by what happened inside the central nervous system. And on the left, you see there is a green area, and the green area is very important because, as we have heard even yesterday, the age has a lot of role in the accumulation of disability, both because of the immunosenescence and the presence of a lot of comorbidities that, unfortunately, they increase with age. So if we look at this screen, it seems that we have a clear separation between the relapsing phase and the progressive phase. Unfortunately, this is not really true. One of the reasons why such a clear separation is not possible is because the mechanisms that are driving the accumulation of irreversible disability in the progressive phase of the disease are quite variable. Here in this very perfect review by Daniel Montaneda, it has been listed a series of different types of mechanisms that contribute. And these mechanisms, they play a role at a different time in the evolution of the disease. They overlap partially. So we don't have just one way to accumulate disability progression from the pathophysiological mechanism. We have many different types of mechanisms. So then the key point became, when does the mechanism of progression becoming prevalent compared to the mechanism of accumulation of disability due to attacks and new lesions? In the classical view, we have here the line that describes the point of separation between the relapsing and the progressive phase. However, some new data do suggest that probably this line is not correct. We have to consider that at least some of these mechanisms can be active since the beginning, the biological beginning of the disease. Please pay attention. The fact that these mechanisms could be very active since the beginning of the disease doesn't mean that the accumulation of irreversible disabilities then since the beginning of the disease, and there is no possibility to halt this type of mechanisms. Of course, there are a lot of methodological aspects that prevent our ability to pick up as early as possible the presence of this type of mechanism and what we define as secondary progressive phase or a primary progressive phase of the disease. Always is a retrospective classification, and sometimes at the time we classify the patient as entered in the progressive phase, we realize that probably this type of definition and shift could be updated by many years before. Why it is so relevant, this discussion? Because, of course, as soon as new drugs will be available, able to target this mechanism in a very specific way, then we need to know when we have to start to use this type of drugs, perhaps in combination with the classical anti-inflammatory drugs. Two really important papers have highlighted the possibility that the onset of progression has to be anticipated by many years in the history of a person with MS. The first paper was a paper from the UCSF group, and this paper was the one responsible of the definition of silent progression. And the second paper is a paper by Ludwig Kappos promoting the concept of PIRA. So the first paper was, I think, very interesting because essentially what they did, they looked longitudinally for more than 10 years to the evolution of the disease using the brain MRI atrophy as a measure of the accumulation of irreversible tissue damage. And they saw that also in patients without any new lesion in the brain during these 10 years, that is the line in violet, accumulated some progressive brain atrophy in absence then from any type of clinical or MRI disease activity. And they interpret that as an evidence that the silent progression is in some way telling us about the early onset of the phenomenon of progression. There is only a problem here. The problem is that the average disease duration in patients followed for these 10 years was more than 10 years. So it was not focused on the early phase of the disease, it was already focused in the intermediate phase of the disease. And we know that in the intermediate phase of the disease, the risk to conversion to secondary progressive MS is very high. And we already know since a very long time that the role of relapses in accumulation of disability decrease progressively during the evolution of the disease. So the very first attacks have a very important role in predicting disability and also in predicting the onset of secondary progressive MS. That is just what you can see here in the box in the inferior part. And with the evolution of the disease, the single attacks has more and more or less value or less role in predicting the accumulation of disability. The second paper, I said, is the paper by Ludwig Kappos. It is so well known, the concept of PIRA, that I don't want to lose too much time about this point again. However, we should really consider that the PIRA, as it has been defined by Ludwig Kappos, has a lot of problems because there are many different factors that I try to summarize here that may really influence this type of definition. And particularly, it is clear now that we have accumulated a lot of papers about PIRA, that PIRA may be persistent or may be reversible. And it is clear that a reversible PIRA cannot be considered like at the time where the patient entered the progressive phase of the disease. Second, it depends the way we assess this evolution independent from attacks. In the paper of Kappos, the definition was based on a composite score, and the composite score has a great value because it enhances our ability to pick up a longitudinal change, but from the other side, it has also the problem of a very low specificity because the more measures you use, the more you have a risk to be wrong in your definition. Second and very important point is that only a sustained PIRA may really reveal the presence of a disease that is evolving. And so if you have a sustained PIRA, then you may really think that you are in some way already detecting the onset of progression, but it is unsustained, reversible. It is much more probably an undetected attack, or if you like, a subclinical MRI activity. And this is absolutely true because in this paper by Fred Lablin, where a very large number of patients have been observed, both patients coming from clinical trials and from observational studies, it was clear that if we use the definition of PIRA restricted to patients with a sustained PIRA, a PIRA that is present also at the end of the observation, the proportion of patients with relapsing remitting showing a PIRA sustain is of the order of 3–4%. So it means that not all PIRA, not all relapsing patients have already evidence of irreversible disability accumulations since the beginning. And a second very important epidemiological study from the Italian registry, using more than 16,000 patients, followed for more than 11 years, confirmed that this is absolutely true. And this study demonstrated that you have, let's say, about half of the relapsing remitting patients followed for this long period with evidence of a confirmed disability accumulation, and that the large proportion of these patients had the disability accumulation because of PIRA condition, but only 27% of patients with PIRA transition to secondary progressive MS, and those who transition were mostly patients with 2 or more episodes of confirmed and sustained PIRA. So the message here is one PIRA is really not revealing so much the entering the progressive phase of the disease. A second major point was the fact that in order to have a very accurate definition of PIRA, you must use in parallel also the evaluation of MRI, because a true PIRA is a PIRA which is not associated at the same time with the presence of MRI activity. A PIRA with MRI activity is a PIRA where the examiner failed to detect something that was clearly there due to a new activity of the disease. And this other Italian study, based on the Italian registry, where this type of analysis was combining together both the evaluation of clinical and MRI activity, reveal again that the majority of patients with accumulation entering the progressive phase of the disease and accumulating disability independent from attacks were patients with presence of some MRI activity. So the true PIRA, again, is a minority of the PIRA process. And this other study from the group of Fred Lablin again demonstrated that what has been seen by our study was absolutely true. You see here different colors. The colors at the top is the dark violet color, is representing in the group of patients with PIRA, which is the proportion of patients with a true PIRA, so a PIRA which is not linked to any MRI activity. As you can see, the proportion is very small. So then someone may see the PIRA concept like a misleading concept. However, it is clear that when we see a PIRA early in the disease course, like in this study of the Xavier Montalban Center, then this type of event, which is not frequent, is in any case an event that is strongly associated with a very high risk of a future conversion to a secondary progressive MS and an accumulation of severe disability. I think this is very clear, as you can see here. So I think that the conclusion is here that, of course, we have to consider that we may clearly anticipate the time the patient start to have a quite clear relevant role of a mechanism of accumulation of disability, which are expression of the phenomenon of progression. However, this type of information has to be used in a very appropriate way, and particularly don't confuse a peer event with a classification of a person with progressive MS. So I will be quite short in the second part of my talk, because if it is really fundamental to anticipate our ability to pick up the progression, unfortunately, at present, even if we are able to reveal very early such a phenomenon, we miss, unfortunately, treatments that are really able to target quite efficiently this type of phenomenon. Again, the aim of intervene in patients with progressive MS today is first to try to take advantage from the two approved drugs we have, and second, to try to use these drugs in the most appropriate way. Which are the drugs that we have here? Well, the drugs are, as you know, the siponimod for secondary progressive MS and the ocrelizumab for primary progressive MS. Of course, this is what happened, I think, here, is what happened in Europe. In North America, a list of other drugs are approved for treatment of progressive MS, provided that it is a progressive MS with attacks. That is the so-called active progressive MS. If we look to what we have seen with the observational studies, it is clear that all these drugs that are listed at the top, interferons and some S1P modulator, this drug, when used very early, they may have some advantage also in progressive MS, but the advantage is mostly in reducing the risk of overlap of attacks. Very little effects, as you can see in the bottom, in terms of ability to protect from the accumulation of disability. I think this study compare what we define today, the highly active treatments against the modest active treatment in secondary progressive MS, and you can see that the two curves overlap completely. So there was this type of comparison revealed that there was no advantage from the high efficacy treatment, with some exception, because for monoclonal NTB, rituximab, this Swedish study showed that, well, if you have a very, very active treatment, then even in secondary progressive MS, you may have some results. So then the question is, all the patients with secondary progressive MS may have such a benefit? Well, not true, because even if we look at the results of clinical trials, this is the siponimod study, in the subgroup analysis post hoc, it was clear that the benefit was there only for some subpopulation of patients, and particularly those with evidence of clinical or MRI activity at the study entry, and those who were younger, less disabled at the time of treatment onset, and with a shorter disease duration. And this is really a fundamental message, because also in the trial in primary progressive MS, ocrelizumab revealed to be more effective in those patients with still some persisting clinical and MRI activity. Again, I think a very fundamental message. So what we have today may still have some impact on the early phase of primary or secondary progressive. However, desperately, we need something more. And of course, we have to fit a lot and to deal with a lot of problems in terms of the future availability of really neuroprotective drugs. I think that this cartoon shows you a bit the complexity and how many different tentatives are there in order to be able to have a new treatment that really target progression. We have no time to go in details, but I want just to show you a couple of possibilities. One is masitinib. I think this is an interesting drug because already in ALS, in a study I was involved, there was some evidence of the ability of this drug that target microglia to slow down the process of accumulation of disability. And a phase 2, I have to say, a small study, revealed that masitinib was able to reduce the accumulation of disability in a 2-year study. There is now a couple of ongoing clinical trials in progressive MS. Let's see what happens. And the second is the story of the BTK inhibitors. We have already heard a lot, even in this meeting, about this, so I will be very fast. The value of this is really the fact that it targets the B cells without destroying B cells, just modulating the activity of B cells, which has, of course, from the theoretical point of view, a lot of advantages on the long-term use of this drug. And second, because of the intense activity on the myeloid cells, macrophages, macrophages, microglia, there is the possibility that the inflammatory activity in the CNS, which is clearly persisting during the chronic phase of the disease, may be turned down quite clearly, and such an effect may also allow a better enhancement of remyelination. Professor Hartung will touch more in detail this problem. So this could be a very interesting possibility. There are a lot of different drugs that are active here. They have a different profile of off-target effects, so probably a different profile in terms of safety, but also a different penetration of the central nervous system, so a different possibility to interact at the central nervous system level. Fenebrutinib is a very interesting BTK inhibitor for many reasons, and a trial is now started in patients with primary progressive MS. Is extremely difficult trial because it's a head-to-head trial with ocrelizumab. So I think not easy trial, but is really what we need from the scientific point of view. And a couple of trials on progressive MS, primary and secondary, are also ongoing with tolebrutinib. There were some safety problems, but the trials are now restarted. And I will not talk about remyelination. And the very last slide is this one. Of course, at the extreme, we have also to consider cellular therapy. The study we performed in San Raffaele in testing the efficacy of neural stem cells with some clear evidence that there were some biological modification due to the administration of neural stem cells intrathecally may also open the door to some other possibility. So my conclusion then is that here, unfortunately, there is only little we can do today for patients with progressive MS. However, something can be done. We really have to use available treatments, and here siponimod and ocrelizumab, but also other B cells, monoclonal anti-B cells therapy have to be used. I think that the Swedish trial, for me, it was very convincing, showing that if you use this type of intervention in the early progressive phase of the disease, in young persons with a shorter phase of progression, we may still think to have some good results. Of course, we have to look at the future in order to try to have something that, when available, we will combine with the traditional anti-inflammatory therapies, because I think that the combination therapy where we target both central and peripheral mechanism of tissue damage are really fundamental. Thank you so much for your attention.